We're integrating 3 critical scenarios here. That's case 1, case 3, and case 15. And they're all designed to really emphasize the critical anatomical landmarks that can be the difference between a swift recovery and a major, major complication. So let's start with case 1. This one is a classic clinical masquerader. We have a 62-year-old woman. She comes in with a 2-day history of sharp, localized, right-sided chest pain.
Right.
And the key findings are these. The physical exam shows point tenderness right over her costal cartilages, and the pain gets dramatically worse when she moves, when she coughs, or even just takes a deep breath.
And crucially, her vital signs are stable.
Completely stable. The full standard cardiac workup, ECG, echocardiogram, chest radiograph, all of it completely normal.
So this scenario, it just perfectly highlights one of the most, one of the most stressful clinical challenges out there, acute chest pain.
Absolutely terrifying for the patient.
Oh, completely. I mean, the patient's subjective experience is terrifying. It often perfectly mimics a myocardial infarction, a heart attack. But those objective findings you mentioned, the localized, reproducible point tenderness, that's what strongly suggests a musculoskeletal origin.
So we're looking at costochondritis.
We're most likely looking at costochondritis, yeah. Or, inflammation of the costosternal joints. It's usually the 2nd through 5th ribs that are involved.
I think the biggest takeaway here for the learner, it's not actually the final diagnosis, it's the process of elimination, right?
It has to be.
When the symptoms are this frightening, what are those immediate life-threatening diagnoses that a clinician has to definitively rule out, even when the exam seems reassuringly local?
Well, that list is mandatory. It's non-negotiable in an acute setting. You have to rule out acute coronary syndromes like a myocardial infarction, of course.
Top of the list.
Always. Then pericarditis, which can sometimes present with a positional pain component, and you might hear a friction rub. You have to think about aortic dissection, pulmonary causes like pleuritis or pneumonia, or a pulmonary embolism.
So PE is high on that list.
Very high. And you even have to consider gastrointestinal issues like severe esophageal reflux or even a rupture. The thing that distinguishes the musculoskeletal pain, what brings you back to costochondritis, is that it's reliably reproduced by specific chest wall movements or direct palpation.
Right, you can point to it.
You can literally put a finger on it. And for reassuring the patient, that's what the clinician has to rely on, the reproducibility and the negative advanced cardiac workup. You explain to them that while the nerve is mediating this pain are near the heart, the source is superficial. It's the architecture, not the engine, that's failing.
Okay, so once we've safely identified the source as the chest wall, let's talk about the anatomy that's actually mediating that pain. The intercostal network. It's such a vast distributed system. Remind us how those intercostal nerves are structured and what they innervate, especially when it comes to systems maybe far beyond the thoracic cavity.
Well, the intercostal nerves are, simply put, the ventral rami of the thoracic spinal nerves, T1 through T12. They're the primary providers of sensory innervation, not just to the skin and over the entire thorax, but also the parietal pleura. That's the outer lining of the lungs.
And their reach is what's really critical here.
Exactly. Their reach is critical. T1 through T11 innervate the thoracic wall itself, but if you look further down, T7 through T12 actually extend their sensory and motor innervation all the way down to the skin and muscles of the anterior and lateral abdominal wall.
Which means
a localized lesion in the lower thoracic spine, or even just referred pain from a pleural irritation, can manifest as pain that you interpret as an internal abdominal issue. And that just adds another layer of complexity to the acute diagnosis.
that potential for referred pain is a critical nugget. And while we're talking about this, this confined space between the ribs, we have to bring up the vascular safety principle. This is a piece of knowledge that moves directly from the textbook into the ER.
Absolutely.
So where exactly does the blood supply run within that intercostal space?
The blood supply involves both posterior and anterior vessels. The posterior intercostal arteries, they originate directly from the descending thoracic aorta. And then the anterior intercostal arteries, they arise from the internal thoracic artery. And all of these run with the corresponding veins and the intercostal nerve, forming that classic neurovascular bundle.
Okay, so here's where the knowledge becomes procedural and absolutely vital. This entire bundle, the artery, the vein, the nerve, it runs precisely where? And how does that dictate safe medical procedure?
It runs right along the lower border of each rib, nestled within what's called the costal groove. And because these structures run together, if you need to place an intercostal insertion like a chest tube for a thoracostomy or a needle for a nerve block,
You have to be careful.
You have to be incredibly careful. You must place it just above the superior margin of the lower rib. If you go below the rib margin, where you might instinctively think there's more space, you put yourself directly in line to damage this critical neurovascular bundle.
And that could cause
Potentially catastrophic hemorrhage or a permanent nerve injury. I mean, this one anatomical detail is absolutely paramount in emergency medical procedures.
that detail alone justifies this whole deep dive, connecting minute anatomy to major clinical safety. Okay, let's pivot from that localized inflammation to a more catastrophic trauma. We're moving to case 3. A 17-year-old male with a gunshot wound to his left flank, and he's now hypotensive and in shock. When a projectile breaches the flank, our immediate focus has to turn to the structures hiding behind the abdominal cavity, the retroperitoneal space.
Indeed. The retroperitoneum is deceptively vulnerable. Because it's fixed right against the back wall, a projectile that traverses the flank will almost certainly involve these organs. And the bleeding can be massive and occult, meaning it's hidden from your initial view.
So it's not obvious.
Not at all. And when you consider the sheer number of critical structures packed in there, you realize how little margin for error exists in that cavity.
And for that, we had the classic mnemonic for the retroperitoneal viscera, SAD pucker. Let's detail that out, really emphasizing how a single bullet path could damage nearly every item on this list, making rapid surgical exploration mandatory.
Okay, SAD pucker. It's a great way to organize the essential, critical retroperitoneal organs that surgeons have to check immediately in penetrating trauma. So, S stands for the suprarenal glands, the adrenals.
Right.
A stands for the major vessels, the aorta and the inferior vena cava. A laceration of either of those is immediately life-threatening.
Obviously.
T is for the duodenum, but specifically the second and third segments, which are fixed retroperitoneally. P is for the pancreas.
Okay.
U is for the ureters, which carry urine from the kidneys to the bladder. C is for the colon, specifically the ascending and descending portions.
The fixed portion.
The fixed portions, exactly. K is for the kidneys. E is for the esophagus, though it's just the abdominal portion, but we include it for completeness. And finally, R is for the rectum. A single entry point can traverse several of these, meaning massive blood loss, internal leakage of bile, urine, feces, organ failure, all are immediate risks that just necessitate exploration.
And before hitting those deep structures, the bullet has to penetrate the abdominal wall. Let's trace those layers from the outside in, giving a detailed understanding of the musculoskeletal architecture that provides what little defense there is.
Okay, so starting from the outside, you have the skin, then you have the subcutaneous layers, camperous fascia, which is a superficial fatty layer, and then scarpous fascia, which is deeper and more membranous.
And then you hit the muscle.
Then you'd hit the primary musculoskeletal defense. It's 3 major layers of the lateral abdominal wall, arranged like plywood for strength. You have the external oblique muscle, then the internal oblique muscle, which runs perpendicular to the external, and then the deepest of the 3, the transversus abdominis muscle.
And deep to that.
Deep to that, you find the fascia extraperitoneal, that's the connective tissue separating the muscles from the lining, and then finally the peritoneum, which lines the abdominal cavity itself. Mapping the entry and exit points across these layers helps the surgeon predict the extent of the internal damage and, the contamination.
In this specific case, the left flank trajectory suggests a really high risk to the spleen. The source material details the vital splenic connections, especially vascularly. Why is damage to the splenic vasculature so dangerous, and what major vessel does its venous drainage contribute to?
Well, the spleen, it's highly vascular and somewhat fragile. It gets its main supply via the splenic artery, which is a critical, kind of tortuous branch of the celiac trunk. Trauma here can lead to rapid, life-threatening hemorrhage, and a splenectomy removing the spleen is often necessary.
And the venous side?
On the venous side, the splenic vein is equally crucial. It drains the spleen, it picks up tributaries from the stomach and pancreas, and most importantly, it joins the superior mesenteric vein to form the hepatic portal vein.
So an injury there jeopardizes the whole portal system.
Precisely. Injury to the splenic vein not only causes massive bleeding, but can also jeopardize the entire portal system, which is vital for directing all that nutrient-rich blood to the liver.
Okay, let's move to case 15. Another scenario of massive blunt force. A motor vehicle accident victim with severe chest trauma. And again, the stakes are the highest, focusing on immediate life threats associated with the structural failure of the thoracic cage.
The initial assessment here is all about life-saving interventions and rapid diagnosis. You have to aggressively look for internal bleeding, a hemothorax or an air leak, a pneumothorax, which could lead to a tension pneumothorax,
Which is an immediate emergency.
a true emergency. You're also looking for a flail chest segment, which causes that paradoxical motion during breathing, and cardiac tamponade, where blood fills the pericardial sac and prevents the heart from beating effectively. Blunt force can also cause severe pulmonary or myocardial contusion, which requires really close monitoring in the hours after the accident.
I want to focus on the nerves here. In that crowded space of the mediastinum, there are these crucial nerves near the heart and lungs that are just highly vulnerable to injury. Which vital nerves are at risk, and what's the functional consequence of damaging them?
Yeah, you have to highlight the phrenic nerve. It arises from C3, C4, C5, and it's crucial because it is the sole motor supply to the diaphragm.
So damage means
Damage or severance leads to paralysis of that side of the diaphragm and significant respiratory distress. Then you have the recurrent laryngeal nerves, which are essential for vocal cord movement. They loop right around the great vessels, making them vulnerable.
and the vagus.
And the large systemic vagus nerve and that dense network of the pulmonary and cardiac plexuses, which modulate heart rate and bronchoconstriction. Damage to any of these nerves can result in immediate, profound systemic dysfunction.
And the great vessels of the thorax. I mean, the sheer volume of blood flow here means that if one is lacerated, it's a rapid death. We need a detailed list of the major arteries and veins supplying and draining this central hub.
Okay, arterial supply. It begins with the massive aortic arch, which arches over the heart and gives rise to the brachiocephalic trunk, the left common carotid, and the left subclavian arteries. Other key vessels include the internal and external thoracic arteries running along the cage.
And drainage.
Venous drainage relies on the large central veins. The brachiocephalic veins, which merge to form the superior vena cava, or SVC. You also have the internal jugulars and the accessory system of the zygos vein, which drains the thoracic wall into the SVC. An injury to any of these large vessels just necessitates immediate, aggressive surgical intervention.
We often overlook the lymphatic system, but the difference in drainage here is a fascinating anatomical asymmetry. It's critical for understanding how infection and cancer can spread. How do the thoracic duct and the right lymphatic duct divide up the body's lymphatic fluid?
The distribution is surprisingly imbalanced. The thoracic duct is the main collector. It's massive, and it drains the entire lower body, the GI tract, the left arm, and the entire left side of the head, neck, and chest. It handles the majority of the body's lymphatic fluid.
And the right side.
Conversely, the right lymphatic duct is much, much smaller. It only drains the right arm, the right side of the head and neck, and the right side of the thorax. The thoracic duct then empties into the venous system at that critical juncture of the left internal jugular and left subclavian veins. And this division is vital. If trauma compromises the thoracic duct, you can see massive systemic fluid and fat loss, a chylothorax.
And finally, still on case 15, that anatomical asymmetry extends to the lungs themselves. Why is the right lung consistently more vulnerable during aspiration events? The bronchial asymmetry.
This is a key procedural nugget. It's relevant for everyone, from pediatricians to emergency physicians. When the trachea bifurcates, the right main bronchus is anatomically different. It's shorter, it's wider, and it runs more vertically. It follows a straighter line from the trachea, almost a direct vertical shot.
On the left.
The left main bronchus is longer and runs at a sharper, more acute angle. It has to travel anterior to the esophagus and the descending aorta. So because of this anatomical alignment, gravity and physics just dictate that any aspirated foreign body or blood or vomit is far more likely to fall directly down into the right lung.
Making the right lower lobe the most common site for aspiration pneumonia.
Exactly.
That concludes our look at acute immediate trauma. We've seen how precise anatomical knowledge directly dictates survival. Now we're going to transition pretty dramatically from external force to internal microscopic failure. Let's move to Section 2, Cutaneous Pathology and Malignancy, integrating Case 2 and Case 8. Okay, Case 2. This involves a 63-year-old farmer presenting with a long-standing patch on his cheek that's progressively grown. The lesion is firm, it's rough, scaly erythematous, and the biopsy shows atypical keratinocytes invading the basement membrane. This sounds like an open and shut case of squamous cell carcinoma, or SCC.
That is the textbook definition. SCC is the second most common tumor of the skin. It arises from the malignant proliferation of epidermal keratinocytes, and you typically see it in areas of chronic sun exposure.
And you have to contrast that with basal cell carcinoma, BCC.
Right. BCC is the most common overall. BCCs often present with those pearly, rolled borders, and they very rarely metastasize. SCC, on the other hand, is more aggressive and typically presents as a firm, scaling, or ulcerated lesion.
The cancer usually doesn't appear overnight. So what's the precursor lesion that often defines the pathway to SCC, and how does the body signal that that process is starting?
The essential precursor is actinic keratosis, or AK. These are really common dysplastic lesions of the epidermis. They're basically areas of damaged skin cells that haven't quite become malignant yet.
And what do they feel like?
Clinically, they're characterized by hyperkeratotic papules. They feel coarse and sandpapery to the touch. It's almost like having a tiny piece of sandpaper stuck to the skin. In some cases, the keratin buildup can be so extreme they form what's called a cutaneous horn.
So getting rid of them is crucial.
It is. Identification and removal of AKs is crucial because they have a measurable rate of progression to invasive SCC. The body is signaling the damage through this visible, tactile roughness.
So we know sunlight, UV exposure, is the primary driver here, leading to DNA damage in those keratinocytes. But our sources list several other potent exogenous risk factors. What else contributes to the development of SCC, showing that the failure mechanism is actually pretty broad?
Yeah, it's a convergence of DNA insults. Besides UV radiation, risk factors include ionizing radiation exposure, maybe historical or occupational. Prolonged immunosuppression is a big one, like in organ transplant recipients where SCC rates are significantly higher.
And chronic inflammation.
Chronic inflammation, yes, from non-healing burns, scars, or ulcers, sometimes we call those marginal ulcers, and even chronic occupational exposure to heavy metals like arsenic. It shows that anything that compromises the cellular environment or chronically overwhelms the DNA repair process just increases your vulnerability.
And that ties directly into genetics. What are the rare genetic disorders that dramatically accelerate this progression, showing that sometimes the flaw is in the repair mechanism itself?
The most dramatic example is xeroderma pigmentosum, or XP. This is a rare, severe autosomal recessive disorder. And the fundamental life-altering problem is a genetic defect in the DNA excision repair mechanism.
So they just can't fix the damage.
The patient's cells simply cannot fix the cyclobutane pyrimidine dimers. That's the specific damage caused by UV light. This leads to an incredibly high lifetime risk of all skin cancers, including SCC, often starting in early childhood. And we should also note albinism, which involves a generalized pigment loss, also increases the risk of all UV-induced skin cancers just due to the lack of natural solar protection.
So moving to prognosis for the patient in case 2, SCC sounds ominous because we associate cancer with metastasis. But what's the typical outlook once it's diagnosed?
For a localized cutaneous SCC, the outlook is actually quite good. While it is locally invasive, metastasis is remarkably rare. It occurs in only about 1% to 5% of cases. Aggressive surgical excision, especially with techniques like Mohs surgery, is usually curative. You're looking at cure rates well over 90% for typical lesions. The key is just early detection before it invades deep into the dermis or surrounding structures.
Okay, now let's jump to case 8, which involves the most feared of skin malignancies, malignant melanoma. A 47-year-old man presents with a suspicious dark lesion that's grown over 2 years. It's displaying color variations and irregular borders. This immediately necessitates the application of the ABCDE rule.
The ABCDE mnemonic is the frontline diagnostic tool for melanoma. It's what separates dangerous lesions from common benign nevea, so asymmetry. One half doesn't match the other.
Go.
Border irregularity. The edges are ragged, blurred, or notched. Color variegation. The presence of multiple shades. Blacks, browns, reds, whites, or blues, all within the same lesion. Diameter. Lesions greater than 6 millimeters are suspicious. That's about the size of a pencil eraser. Devolving. Changes in size, shape, color, or elevation over time. Any recent changes are a massive red flag.
The cellular origin of melanoma is what makes it so aggressive and links it back to fundamental embryology. Where do melanomas originate, and what does that tell us about their potential behavior compared to something like SCC?
Well, melanocytes, the pigment-producing cells, they originate embryologically from neural crest tissue. This is a migratory tissue that gives rise to many parts of the nervous system, the adrenal medulla, and, crucially, the melanocytes. This highly migratory and invasive lineage explains why melanomas often exhibit such unpredictable, aggressive, and highly metastatic behavior. It's just not like the typically localized growth of an SCC. The melanocytes settle in the stratum basal, the deepest layer of the epidermis.
And besides solar exposure, what are the primary risk factors for developing melanoma?
Well, beyond those intense, intermittent, blistering sunburns early in life, key risks include having numerous benign nevi, particularly atypical or dysplastic nevi, Genetic predisposition, so strong family history of melanoma, is also a big one, and having certain complex syndromes.
If we were to zoom in on the pathologist's report for this patient, what is the single, absolute, most important prognostic factor? This is the thing that defines the patient's fate more than almost any other variable.
The most critical prognostic indicator is, unequivocally, the tumor thickness or depth. It's often measured in millimeters, the Breslow depth. Melanoma is typically curable if it's caught before it invades the basement membrane, but once that tumor thickness exceeds 4 millimeters, the 5-year survival rate just plummets dramatically, falling to around 40–50%.
And there's a protein marker as well.
Yes, the expression of the S100 protein in the serum is also used. Elevated S100 correlates strongly with a worse prognosis, as it's often indicative of distant spread.
Speaking of spread, how does melanoma typically spread once it begins that vertical growth phase?
Melanoma starts by spreading superficially, horizontally. But once it enters the vertical growth phase, it penetrates the dermis. From there, it spreads through both the lymphatic system, leading to metastases in regional lymph nodes.
Which is often the first sign of spread.
Often the first sign, yes. And it also spreads hematogenously through the blood. Melanomas are notoriously known for their affinity for distant sites, including the brain, where they are often hemorrhagic, the lungs, the liver, and the bones.
So treatment for melanoma hinges entirely on the stage, but what are the foundational strategies?
For thin, localized lesions, the treatment is a wide surgical excision with clean margins. If the lesion is thick or there's evidence of regional spread, surgical removal is combined with a sentinel lymph node biopsy, and if that's positive, a regional lymph node dissection. But today, immunotherapy like PD-1 inhibitors and targeted therapies like BRAF inhibitors have really revolutionized the treatment of advanced metastatic melanoma. They offer hope that was just unavailable a decade ago.
We've covered the exterior, the skin, and 2 major malignancies. Now we are going deep into the structural interior, where inherited flaws compromise the body's scaffolding. Let's move to Section 3. The fragility of connective tissue and muscle, using cases 12, 9, and 11 to explore these hereditary disorders. Case 12 presents a really heartbreaking scenario. It's an 8-year-old girl with recurrent, unexplained skeletal fractures, 3 of them, femur, tibia, and elbow, despite having no history of severe trauma or contact sports. The likely diagnosis for this pattern is osteogenesis imperfecta, or OI.
Yes, OI is often called brittle bone disease, and it's the most likely diagnosis when you see recurrent fractures without adequate trauma. It's an inherited disorder, typically autosomal dominant, and it's caused by fundamental defects in the structure or quantity of type I collagen. The mutations are usually found in the COL1A1 or COL1A2 genes. These flaws just make the bone matrix structurally unsound, leading to extreme fragility and porous, thin bone cortex.
What's really important to stress here is that OI affects more than just the skeleton. Because type I collagen is a foundational structural protein throughout the entire body, what are the systemic pathologic findings we have to look for beyond just the bone?
The defects are absolutely systemic. We often see blue sclera. The white part of the eye appears blue because the thin layer of connective tissue, which is rich in type I collagen, allows the underlying choroidal pigment to show through.
That's a classic sign.
A classic sign. Other major findings include cardiac insufficiency, commonly mitral valve prolapse or aortic root dilation, progressive hearing loss due to defects in the ossicles, basilar skull deformities, and kyphosiliosis, which can lead to restrictive lung disease.
This necessitates a detailed review of the body's most common protein, collagen. Our sources provide a perfect breakdown of the 4 major types. Let's list them and their primary locations, as this is essential for understanding pathology across the whole body.
Understanding the types of collagen is foundational. So type I collagen is the most common. It's found in tissues requiring high tensile strength. Bone, skin, tendon. This is the primary defect in OI.
Okay.
Type 2 collagen is found in tissues that require elasticity and cushion, so cartilage. Type 3 collagen is in highly distensible tissues, reticular tissue, arteries, and the uterus. And finally, type 5 collagen is found exclusively in the basement membrane, forming the structural filter.
Okay, now let's follow the synthesis assembly line for collagen, step by step. It's a remarkably complex process that relies on precise timing and specific cofactors. Where does the process begin, and how is it chemically modified to achieve that tensile strength?
It's a multi-step factory process that spans both intracellular and extracellular space. It starts inside the cell. First, you have synthesis and translation. Procollagen strands, rich in that repeating sequence glycine proline X, are synthesized in the ribosome and then fed into the rough ER.
And then what happens in the ER?
Inside the rough ER and Golgi, the proline and lysyl residues are chemically modified. They are hydroxylated. And this modification is absolutely essential, as it allows for the strong, covalent cross-linking that gives collagen its enormous strength.
And from there,
From there, 3 of these modified procollagen strands assemble into a stable triple helix. That helix is then secreted out of the cell into the extracellular space. And once it's outside, specific enzymes cleave the propeptides, turning the procollagen into tropocollagen, which spontaneously polymerizes into strong, stable collagen fibrils.
that hydroxylation step you mentioned is the absolute weak link in the chain because it requires a specific outside-sourced cofactor. This connects the modern understanding of OI to a historically devastating disease, scurvy.
Exactly. The hydroxylation of proline and lysyl residues, mediated by enzymes like proline hydroxylase, requires a necessary cofactor, ascorbic acid or vitamin C. A deficiency of vitamin C prevents proper hydroxylation, leading to defective collagen synthesis that just cannot form stable cross-links.
And that manifests as scurvy.
This systemic structural failure manifests as scurvy, characterized by poor wound healing, easy bruising, gingival hemorrhage, anemia, and failure of skeletal growth, all consequences of compromised collagen stability. It really shows how a simple nutritional deficiency can mimic an architectural catastrophe at the molecular level.
Let's transition now from faulty scaffolding to faulty muscle machinery with Case 9. Duchenne muscular dystrophy, or DMD. We have a 3-year-old boy showing delayed motor skills, difficulty climbing stairs, and he's using his arms to push himself up, the classic Gower sign.
DMD is a severe, devastating X-linked recessive disorder, primarily affecting boys. The underlying pathogenesis is a deficiency or a complete absence of the large protein called dystrophin. Dystrophin is massive, 23,000 kD, and it acts as a crucial molecular shock absorber, linking the muscle cytoskeleton to the extracellular matrix. Without it, the muscle fibers, the sarcolemma, they tear and suffer damage every single time the muscle is contracted.
The prognosis here is grim and rapid. What is the typical life course for these patients, and what is the primary cause of death?
DMD is relentlessly progressive. The patient's muscle tissue, particularly in the proximal limbs, is gradually replaced by fat and fibrous connective tissue. Patients typically lose the ability to walk by their early teens and become wheelchair dependent. Death often occurs by the end of the second decade, primarily due to cardiac failure, a dilated cardiomyopathy, or respiratory failure, as the muscles required for breathing also degenerate.
From a genetics perspective, it's X-linked recessive. So if the mother is a known carrier, what is the clear inheritance probability for any future children?
Since the mother has 2 X chromosomes and is a carrier, for every pregnancy there is a 50% chance of passing on the mutated X allele. Therefore, for a second son, there is a 50% chance he will inherit the condition. For a daughter, there is a 50% chance she will be an asymptomatic carrier.
But it's not always inherited.
That's important to remember, yes. About 1/3 of DMD cases are spontaneous, arising from a new, non-inherited mutation which complicates the counseling process.
The sources compare DMD to its milder cousin, Becker muscular dystrophy, BMD. What's the functional difference between the two that explains the vast difference in prognosis? We hear about the B band staying constant in length in BMD. What does that signify in practical terms?
The key difference is the type of defect in the dystrophin protein. In DMD, the gene is often frame-shifted, meaning the protein is essentially non-functional or entirely absent. It's a total structural collapse. In BMD, the gene is often mutated, but the resultant dystrophin protein is still produced. It's just structurally abnormal or truncated.
It's partially functional.
Exactly, it's partially functional. Because the protein retains some stabilizing capability, the muscle integrity is preserved for much longer. That stability is reflected in the structural elements of the sarcomere, like the B band, which remains relatively stable. This allows BMD patients to retain ambulation well past 15 years, often into adulthood, leading to a much better long-term prognosis.
Our final hereditary disorder in this section is Case 11, neurofibromatosis, or NF. We are dealing with hereditary tumors of the nerve sheath, often involving multiple systems.
NF encompasses 2 main syndromes, NF type 1, which is also known as von Recklinghausen disease, and NF type 2, both in autosomal dominant disorders. This means that if one parent has the gene, there is a 50% chance of passing it on to any child. NF1 is significantly more common and has broader clinical manifestations.
Let's focus on NF1. Where is the genetic flaw and what is the role of that gene product?
The NF1 gene is located on chromosome 17. It codes for a protein called neurofibromin, which is a key tumor suppressor protein. Specifically, it's a member of the guanosine triphosphatase activating protein family. When this tumor suppressor function is lost, often due to a mutation in both copies of the gene, you get uncontrolled cellular proliferation, which leads to the characteristic benign tumors, the neurofibromas.
And what are the classic must-know clinical features of NF1 that allow for a diagnosis?
The diagnostic features are often cutaneous and easy to spot. First, 6 or more café au lait spots, which are light brown skin patches greater than 5 millimeters in diameter.
Good.
Then multiple neurofibromas, those benign tumors of peripheral nerve sheaths that present as soft subcutaneous nodules. Also axillary or inguinal freckling, which is freckling in unusual non-sun exposed places.
And in the eye?
In the eye, you look for Lisch nodules, which are benign iris hamartomas. And you can also see optic gliomas, tumors of the optic nerve, and specific bony lesions like sphenoid dysplasia.
The embryological link here is essential, tying back to our melanoma discussion. Why do NF signs manifest in such diverse parts of the body, from the skin to the nerves?
It's the common thread of the neural crest cells. Many of the features of NF1, the café au lait spots, the freckling, and the neurofibromas are all linked to abnormal descendants or overgrowth of tissues derived from the neural crest. It really emphasizes how a single genetic failure on chromosome 17 can cascade through development to affect multiple, seemingly unrelated systems.
Case 11 also mentions the NF2 presentation, involving bilateral acoustic neuromas, which draws our attention to cranial nerve 8th. Tracing the path of the vestibulocochlear nerve from the sensory organs to the brainstem is crucial for understanding where these tumors cause damage.
Right. The vestibulocochlear nerve, CN8th, originates in the internal ear. It senses sound in the cochlea and balance from the vestibular canals, both of which are housed within the petrous bone of the skull. It then travels centrally, passing through the internal acoustic meatus, a narrow bony canal, before connecting to the brainstem at the precise junction of the pons and the medulla.
And the tumor grows along that path.
Exactly. A schwannoma, a nerve sheath tumor associated with NF2, typically develops along this path, compressing the nerve as it exits the bone. This leads to progressive sensorineural hearing loss, tinnitus, and balance problems.
We have finished our look at genetic and traumatic catastrophe. Now we enter the slow, grinding process of structural degradation and autoaggression. We're moving to Section 4. The spectrum of joint disease, where we contrast the mundane wear and tear of age with the highly complex systemic inflammatory attacks of autoimmunity, covering 4 vital cases. So we start with Case 10. Osteoarthritis, OA. This is a 65-year-old man presenting with chronic, progressively painful and stiff joints, particularly his hips and lower back. The clinical hallmark here is that his pain is exacerbated by mechanical activity and, crucially, it's relieved by rest.
That history of pain relieved by rest is the cornerstone for distinguishing OA from inflammatory arthritides. OA is the most common joint disease. It's characterized by symmetric, gradually progressive joint pain and stiffness, but without the systemic signs like fever or fatigue that you'd associate with autoimmunity. It is fundamentally a mechanical failure of cartilage repair.
If this patient is sent for an X-ray, there are 4 classic features of OA that are summarized by the mnemonic OLOS-S. Let's review those radiographic hallmarks and what they physically represent in the failing joint.
Okay, the LOSS mnemonic captures the classic radiographic picture, loss of joint space. This is the visual manifestation of the articular cartilage being eroded away.
Right.
Osteophytes. These are bone spurs, new bone formation at the margins where the periosteum is stressed because there's no cushioning left. Subchondral sclerosis. That's increased bone density right beneath the stressed cartilage, representing the body's reaction to increased mechanical load. And the final S, subchondral cysts. Fluid-filled cavities beneath the joint surface, often formed as joint fluid, is forced into microscopic bone defects.
So what's the core pathophysiology here? What is actually failing in the joint that leads to all these findings?
OA involves non-inflammatory change. It's the deterioration and progressive degeneration of the articular cartilage, that smooth, protective surface on the ends of the bones. This is caused by a complex interplay of metabolic, biomechanical, and biochemical factors. Mechanical stress causes the chondrocytes, the cartilage cells, to fail and release destructive enzymes like metalloproteinases. And once that protective, smooth cartilage is gone, bone rubs against bone. That causes intense pain, it generates those osteophytes, and it initiates a painful inflammatory cycle.
And we have to be able to differentiate OA from other common conditions.
Yeah.
How does the stiffness of OA differ specifically from the stiffness of, say, rheumatoid arthritis?
Timing is everything. When you're comparing it to systemic autoimmunity, RA stiffness lasts for more than 1 hour. It's a systemic inflammatory process that takes a long time to ease, and it involves soft tissues. By stark contrast, the stiffness associated with OA is purely mechanical. It typically lasts less than 30 minutes, and it improves quickly with movement, though activity later in the day will exacerbate the deep pain. Of course, clinicians also have to rule out highly acute issues like septic arthritis or gout.
Given the irreversible nature of cartilage loss, what are the primary treatment goals for OA?
Treatment focuses entirely on reducing pain and maintaining mobility. Pharmacologically, we use NSAIDs, nonsteroidal anti-inflammatory drugs, and acetaminophen. Weight loss is often the most effective non-pharmacological intervention just to reduce mechanical stress. For acute localized pain flares, we might use intra-articular injections of glucocorticoids or hyaluronic acid.
But eventually,
Eventually, once the degeneration is severe enough to significantly impair quality of life, the only truly effective long-term solution is surgical intervention, usually total joint replacement.
okay, let's shift gears completely to case 13, rheumatoid arthritis, RA. This is a 62-year-old woman presenting with pain and symmetric swelling in her hands and feet for months, along with morning stiffness that lasts for well over an hour, and palpable subcutaneous nodules. This is a systemic attack.
This is the quintessential chronic systemic autoimmune disease. The distinguishing clinical hallmarks are crucial. Symmetric involvement of multiple joints, persistent arthritis in 3 or more joint areas for more than 6 weeks, and the hallmark of morning stiffness lasting more than 1 hour.
And the small joints are key.
Exactly. The involvement of the small joints of the hands and feet, the MCP and PIP joints, is highly characteristic, and the presence of those rheumatoid nodules suggests more severe disease.
The pathogenesis is complex, driven by an immune response. How does this systemic chaos translate into localized joint destruction?
It's an immune cascade. T cells, specifically CD4 plus T cells, and B cells infiltrate the synovium. They attract macrophages and trigger a massive release of pro-inflammatory cytokines, especially tumor necrosis factor, or TNF, and interleukin-1. This chronic inflammation causes the synovial lining to thicken and transform into a highly destructive mass of granulated tissue that we call a pannus.
And that pannus is the problem.
That pannus is the problem. This tissue actively invades and destroys the adjacent articular cartilage, the underlying bone, and the joint capsule, leading rapidly to permanent joint deformation and erosion.
Diagnosis relies heavily on laboratory tests and serology. Which antibodies help confirm RA, and which one is the most specific marker that can often predict disease severity?
We routinely test for inflammatory markers like ESR and CRP and 2 key antibodies. First is rheumatoid factor, or RF, which is an IgM antibody against the patient's own IgG. While RF is sensitive, it's not highly specific. The more sensitive and highly specific antibody for RA diagnosis is the anticyclic citrullinated protein antibody, or anti-CCP.
And that one is more predictive.
Yes. A positive anti-CCP is often present early and is frequently predictive of more aggressive, erosive disease.
Let's visualize the damage. Describe the classic irreversible hand deformities we see in advanced RA patients.
The deformities result from chronic inflammation, weakening tendons, joint capsules, and eroding bone. They include, first, ulnar deviation. The fingers drift laterally, pointing toward the little finger side, caused by joint instability and tendon slippage.
Okay.
Then you have swan neck deformity, characterized by hyperextension of the proximal interphalangeal joint, the PIP joint, and compensatory flexion of the distal interphalangeal joint, the DIP. And then the reverse, boutonniere deformity, flexion of the PIP joint and hyperextension of the DIP joint.
And since RA is systemic, the pathology isn't confined to the joints. What are the major non-articular manifestations that complicate the prognosis?
RA affects nearly every organ system. Common manifestations include musculoskeletal issues like severe osteopenia and secondary osteoporosis. Pulmonary complications include pleuritis, interstitial lung disease, and rheumatoid pulmonary nodules.
And cardiac?
Cardiac issues are significant, with accelerated coronary artery disease and pericarditis being common. Other manifestations include rheumatoid vasculitis, scleritis, which is eye inflammation, and muscle atrophy.
So the treatment strategy here has to be dramatically different from OA. It must be aggressive and disease-modifying, targeting the immune response itself. What are the current pharmacological strategies?
We use a multi-tiered approach. NSAIDs and glucocorticoids are used for rapid symptom relief during acute flares. But the crucial long-term approach relies on disease-modifying anti-rheumatic drugs, or DARTs.
Like methotrexate.
Methotrexate is the anchor drug due to its efficacy and safety profile. Also, sulfasalazine and hydroxychloroquine. For patients who fail these conventional treatments or have highly aggressive disease, we move to biologic agents like TNF inhibitors such as etanercept or B-cell depleters like rituximab. These specifically target the inflammatory components to suppress the inflammation and halt that destructive pannus formation.
Moving to case 17. Systemic lupus erythematosus, SLE, often nicknamed the Great Mimic because of its hugely varied presentation. We have a young woman with fatigue, polyarthritis, recurrent fevers, and the characteristic rash over her cheeks and nose.
SLE is a multi-system autoimmune connective tissue disease, and it predominantly affects young women in their 20s and 30s. Its complex pathophysiology involves the body producing autoantibodies against various cellular components. This leads to the formation of immune complexes that deposit in tissues throughout the body, triggering widespread inflammation and damage.
Diagnosis hinges on antibody testing. ANA is sensitive, but what are the highly specific antibodies we look for, and what does that sensitivity versus specificity trade-off mean in practice?
The anti-nuclear antibody, or ANA test, is exceptionally sensitive. A negative result usually rules out SLE, but it's not specific. Many healthy people or those with other conditions can be ANA positive.
It's a screening test, really.
It's a great screening test. For specific diagnosis, we rely on anti-double-stranded DNA, or anti-dsDNA, and anti-Smith or anti-ISM antibodies. Anti-dsDNA titers often correlate closely with disease activity, particularly renal involvement.
And there's that curious false positive connection in some serological tests that can cause real diagnostic confusion.
That's right. Patients with SLE often produce antiphospholipid antibodies. These are antibodies against various components of the clotting cascade. And these antibodies can cross-react with the cardiolipin antigen used in specific syphilis screening tests like the VDRL or RPR, leading to a false positive result for syphilis, which can really complicate the patient's history.
The clinical diagnosis requires meeting 4 of the 11 classification criteria, which we organized by the mnemonic SAP BrainMD. Let's lay out those criteria, focusing on the diversity of organ involvement that earns SLE its Great Mimic title.
Okay, the 11 criteria are serositis, so inflammation of the linings of the lung or heart, oral ulcers, usually painless lesions, arthritis, which is non-erosive, photosensitivity and unusual sensitivity to sunlight, blood changes like anemia or low white cells or platelets, renal involvement, so proteinuria or cellular casts in the urine, ANA positive, immunologic changes, the presence of those anti-dsDNA or anti-syphilis antibodies, neurologic signs, seizures or psychosis, malar rash, the classic butterfly rash, and discoid rash, which are scaly scarring lesions.
Renal pathology is often the most serious consequence of SLE, determining long-term mortality. What are the typical findings, including the pathognomonic histological lesion?
Lupus nephritis, kidney inflammation, is common and often dictates the prognosis. The most common and severe form is diffuse lupus nephritis, which is class 4. Histologically, the immune complex deposition causes the glomerular basement membrane to thicken, leading to the characteristic wire loop lesions.
Wire loop lesions.
To visualize this, these loops are effectively massive deposits of immune complexes acting as physical obstacles, blocking the filtration process and leading to chronic renal failure if it's left untreated.
And finally, what are the common medications that can cause a reversible drug-induced lupus syndrome?
Drug-induced lupus tends to be milder and resolves when the offending medication is stopped, provided you identify it quickly. The classic culprits include the vasodilator hydralazine, the antiarrhythmic procainamide, and sometimes the antibiotics minocycline and the tuberculosis medication isoniazid.
Our last systemic autoimmune disease in this section is case 18, systemic sclerosis or scleroderma. This patient shows fatigue, difficulty swallowing, stiffness in the hands, plus the painful, dramatic color changes in her fingers when exposed to cold.
Scleroderma is defined by widespread fibrosis, thickening, and hardening of the skin and internal organs. It's caused by excessive collagen deposition and vascular damage. We define it in 2 forms: diffuse systemic sclerosis, which involves widespread skin thickening and rapid, severe visceral organ involvement.
And the other?
And limited systemic sclerosis, which is often confined to the skin distal to the elbows and knees and on the face.
The cold sensitivity you mentioned is Raynaud phenomenon. Explain the mechanism and why it's so central to scleroderma pathology.
Raynaud phenomenon is an exaggerated, cold-induced vasoconstriction in the peripheral digits. The small arteries spasm tightly, leading to a triphasic color change, pallor or white due to lack of blood flow, cyanosis, blue, due to deoxygenated blood pooling, And finally, hyperemia, red, as the vessels relax. It is central because the underlying vascular damage and subsequent ischemia is a key component of scleroderma pathology, and it can lead to fingertip ulcers and tissue loss.
For the diffuse form, what are the primary visceral organs involved and why is that so dangerous?
Visceral involvement is the major cause of mortality and morbidity. It frequently affects the GI tract, causing severe esophageal dysmotility, difficulty swallowing, and reflux due to fibrosis. Crucially, it damages the heart, causing myocardial fibrosis, the kidneys, causing scleroderma renal crisis and hypertension, and the lungs, leading to interstitial lung disease and pulmonary hypertension.
And that's often the cause of death.
Yes, pulmonary hypertension is one of the leading causes of deaths in diffuse scleroderma.
Serology again helps us differentiate the two forms. Which antibodies are specific to the diffuse versus the limited forms?
Anti-DNA topoisomerase I, also called anti-CL70, antibodies are highly specific for the diffuse systemic sclerosis form, which correlates with more severe lung and renal involvement. In contrast, anti-centromere antibodies are highly characteristic of the limited systemic sclerosis form.
The limited form is often summarized by the mnemonic CREST syndrome. Let's break down those 5 distinct findings.
CREST encapsulates the 5 features of limited scleroderma: calcinosis, calcium deposits under the skin; Raynaud phenomenon, esophageal dysmotility; sclerodactyly, skin thickening and tightness localized to the fingers and hands; and telangiectasia, small dilated blood vessels or spider veins appearing on the skin.
And treatment for scleroderma focuses heavily on managing these systemic complications.
That's right. Since we cannot reverse the fibrosis, treatment is largely supportive and organ-specific. We treat Raynaud's with calcium channel blockers. Proton pump inhibitors manage reflux. For severe inflammatory complications, particularly lung disease, potent immunosuppressants like methotrexate or cyclophosphamide are sometimes deployed to slow the progression of fibrosis and preserve lung function.
We have now spanned the entire field of systemic disease. We return now to physical breakdown and acute localized failure in Section 5. Orthopedic injuries, and anatomical vulnerabilities. Case 7 involves a young athlete who suffered a sharp knee pain and heard a pop when making a quick pivoting turn while her foot was planted. This immediately makes us think of the deep intracapsular ligaments of the knee.
The knee is structurally complex. It relies on 2 sets of ligaments. The cruciates are intracapsular. The anterior cruciate ligament, or ACL, originates on the tibia and inserts on the lateral femoral condyle. Its primary function is to prevent the tibia from displacing too far anteriorly relative to the femur.
And the PCO.
The posterior cruciate ligament, the PCO, is stronger and prevents the tibia from displacing posteriorly. They're named for where they attach on the tibia.
How do these crucial structures work in concert with the menisci and collateral ligaments to provide stability during complex movements like twisting and pivoting?
Well, the cruciates check both excessive flexion and extension, so they're essentially stabilizing the knee across its entire range of motion, and they are primary restraints against internal and external rotational movements. The medial and lateral menisci, those half-moon-shaped fibrocartilage structures, are essential shock absorbers, and they improve the conformity of the joint surfaces.
And they have a key vulnerability.
A critical anatomical vulnerability of the menisci is that they are mostly avascular, especially the central portion. They have very poor blood supply, which is why tears often fail to heal without surgical repair.
Regarding frequency of injury, which ligament of the knee is most often injured? And why is the ACL so commonly torn compared to the PCO?
Well, the medial collateral ligament, the MCL, is anatomically weaker than the cruciates and is injured more often by valgus stress. Within the cruciates, ACL tears are far more common than PCL tears, maybe 8-to-1 over PCL. That's often due to the hyperextension, rapid deceleration, or twisting movements typical in sports. PCL tears usually require massive force directed backward on the tibia, like a dashboard injury in a car accident.
And this leads us directly to the classic catastrophic athletic injury, the unhappy triad. Explain the exact mechanism of injury and the 3 structures damaged simultaneously, showing how a single force vector causes this multi-part failure.
The unhappy triad is a common term for a complex 3-part injury. It typically occurs in contact sports when the foot is planted firmly on the ground and a powerful force is applied to the outside or lateral side of the knee, a valgus force. This valgus force simultaneously stresses and damages the 3 structures essential for stability on the medial side of the knee.
And those 3 are?
1. The medial collateral ligament, the MCL. It's torn first due to the direct valgus stress that opens the medial joint space. 2. The anterior cruciate ligament, the ACL, torn second due to the rotational forces and anterior displacement of the tibia caused by the impact. And 3, the medial meniscus, which is often torn because of its strong structural attachment to the damaged MCL, shearing it off the tibial plateau. This combined injury just represents a complete failure of the primary restraints.
Let's move superiorly to the shoulder in case 16. Rotator cuff tears. A 63-year-old woman complains of chronic pain and struggles to lift her arm after overstretching. The diagnosis is highly suggestive of a rotator cuff tear.
It's the most likely diagnosis for chronic shoulder pain and weakness, especially in an older patient following chronic wear or a minor fall. It's crucial to differentiate. In younger, typically overhead-throwing athletes, the pain is often tendinitis inflammation and irritation. In the older population, the tendons are degenerated and prone to tearing outright.
We use the ascites mnemonic for the 4 tendons involved. Let's list them and their primary actions, because the functional loss dictates which muscle is likely damaged.
Okay, the ascites muscles and their actions are supraspinatus. Its primary action is initiating the first 20 degrees of arm abduction, lifting the arm away from the body.
Yeah.
Infraspinatus. Primary action is external rotation. Teres minor also aids in external rotation. And subscapularis. Its primary action is internal rotation.
The functional loss is tied directly to the nerve supply. Let's break down the specific innervations for these 4 key muscles, showing the different root levels involved.
This is a critical anatomical detail. The supraspinatus and infraspinatus are both supplied by the suprascapular nerve, C4-C6. The teres minor is supplied by the axillary nerve, C5-C6, and the subscapularis is supplied by the upper and lower subscapular nerves, C5-C7. A full tear of the supraspinatus will result in the inability to initiate abduction, leading the patient to rely on trick movements or the deltoid for the rest of the range of motion.
Now we go back down the limb to case 5. A 72-year-old woman with severe osteoporosis who falls on her hip and suffers a femoral neck fracture. The primary concern is the massive, potentially irreversible complication of avascular necrosis, or AVN.
The primary complication and the critical clinical knowledge point is the high risk of avascular necrosis, AVN, of the femoral head. A displaced fracture of the femoral neck often disrupts the blood supply to the head of the femur, and given the patient's age and likely existing vascular fragility due to osteoporosis, the consequence is rapid bone death.
Which specific arteries are primarily responsible for supplying the femoral head, and which one is the often insufficient backup?
The major supply comes from the medial and lateral circumflex femoral arteries, which are branches of the deep femoral artery. These run proximally up the neck of the femur, making them incredibly vulnerable to fracture and shearing forces. The minor, often insufficient contribution comes from the small artery of the ligamentum teres, which is a branch of the obturator artery. If the circumflex arteries are severed, this minor supply is rarely enough to save the femoral head, leading to collapse and subsequent joint replacement surgery.
The hip joint itself is a powerful articulation. Let's define the 3 bones that contribute to the acetabulum, the socket that articulates with the femur.
The hip joint is formed by the head of the femur articulating with the acetabulum. The acetabulum is a fusion point of 3 bones at the pelvis. The ilium, which is the large upper wing, contributing the superior portion. The ischium, the lower posterior part, and the pubis, the anterior part. The strong articulation and surrounding ligaments make it exceptionally stable, but when failure occurs, it's often catastrophic and requires complex reconstruction.
Assuming the fracture is fixed, the patient must undergo bone healing. Let's detail the 3 distinct overlapping stages of fracture healing, focusing on the development and fate of the callus. Why is this slower in the elderly patient in case 5?
Bone healing is a process of organized repair that takes time. First is the inflammatory phase. It starts immediately with the formation of a hematoma at the fracture site. Growth factors are released, initiating the repair.
Then the callus forms.
Then the reparative phase, or callus formation. This is where progenitor cells, derived from the inner periosteum and the endosteum, migrate and proliferate. They form new blood vessels and lay down a soft callus of cartilage and woven bone to bridge the gap. This soft callus is eventually replaced by hard endochondral bone formation.
And finally,
the remodeling phase. This is the slow, continuous process where the ossified callus undergoes structural remodeling. The bone slowly organizes along lines of stress, following Wolff's law, restoring the original strength and contour. This phase takes months or even years, and in elderly patients, reduced blood supply, underlying osteoporosis, and reduced cellular activity severely slow the entire process, leading to a much higher risk of delayed union or non-union.
our final anatomical vulnerability in this section is case 6, hernias. We have a newborn with a scrotal mass. The immediate necessity is to differentiate between a hydrocele, which is fluid, and an actual hernia, which contains tissue or organ content.
Differentiation is critical, especially in pediatrics. A hydrocele is simply a collection of fluid around the testis. It's often congenital, resulting from a persistent connection to the peritoneal cavity. Critically, a hydrocele will transilluminate bright light. It'll appear bright and glowing because it's only fluid. A hernia, which contains bowel or omentum, will block light and feel doughy or solid.
To understand the difference between direct and indirect hernias, we must define the anatomical landmark, the Hasselbalch triangle.
The Hasselbalch triangle, or the inguinal triangle, defines the area of inherent weakness in the anterior abdominal wall. Its borders are the lateral border of the rectus abdominis muscle as the medial boundary, the inferior epigastric vessels as the lateral boundary, and the inguinal ligament as the inferior boundary.
Now, using that triangle, how do we distinguish the two most common types of inguinal hernias based on their path through the abdominal wall?
Okay, so direct inguinal hernias are usually acquired later in life and are caused by a breakdown or weakness in the floor of the inguinal canal. They emerge medial to the inferior epigastric vessels, essentially pushing directly through the Hasselbalch triangle. They rarely descend fully into the scrotum.
And indirect.
Indirect inguinal hernias are congenital defects. They follow the original path of testicular descent. They enter the deep inguinal ring, which is located lateral to the inferior epigastric vessels. They travel the entire length of the inguinal canal and often descend fully into the scrotum. They're far more common, especially in children, because they result from the failure of the processus vaginalis to close.
That indirect hernia follows the spermatic cord. What key contents are packed within that cord structure?
The spermatic cord is a complex highway containing the vas deferens, the testicular artery, the highly convoluted network of veins called the pampiniform plexus, which is crucial for temperature regulation, lymphatics, nerves, and the enveloping chromastric muscle and fascia.
We've covered trauma, genetics, autoimmunity, and structural failure. Our final two cases shift us to metabolic catastrophe and peripheral nerve compression. We move to section 6. Case 20 focuses on gout. A 40-year-old man wakes up with excruciating acute pain in his left big toe, the first metatarsophalangeal joint, a condition we know as podagra. He links it to a recent dietary indiscretion involving purine-rich foods. This is classic hyperuricemia presenting as a fiery joint.
This is the hallmark of gout. It's a form of monoarticular arthritis caused by the deposition of monosodium urate crystals in the joint spaces. When you're diagnosing acute joint pain, the differential must be narrow and decisive. You have to consider septic arthritis, which is an infection and an immediate emergency, pseudogout, which is calcium pyrophosphate deposition, and gout.
Uric acid is the end product of purine metabolism. We can break the causes of hyperuricemia down into two fundamental categories, those who produce too much and those who excrete too little.
Let's start with causes of uric acid overproduction, the turnover issue. This category accounts for about 10% of cases. It's often due to excessive cell breakdown or turnover, like in patients with lymphoproliferative diseases, those undergoing chemotherapy, hemolytic disease, or patients with large areas of chronic psoriasis. It can also be caused by rare inherited enzyme defects, specifically Lesch-Nyhan syndrome or PRPP synthetase overactivity, which accelerate purine synthesis.
But most cases are the other category.
The vast majority. Causes of uric acid under excretion, the kidney issue. This accounts for 90% of hyperuricemia cases. It's caused by the kidneys failing to adequately excrete uric acid. This can be due to dehydration, impaired overall renal function, or the use of certain medications that inhibit renal excretion, notably diuretics like thiazides and the immunosuppressant cyclosporine A. Lactic acidosis also impairs excretion by competing with uric acid for transport.
The definitive diagnosis comes from analyzing the joint fluid via arthrocentesis. What is the classic finding for gout under polarized light microscopy?
The definitive test identifies needle-shaped, strongly negative birefringent crystals in the synovial fluid. By convention, when they're aligned parallel to the light filter, they appear yellow. This is crucial for differentiation. Pseudogout, caused by calcium pyrophosphate deposition, presents with rhomboid-shaped positive birefringent crystals, which look blue when parallel.
Let's look at the crucial two-pronged treatment strategy, managing the acute attack versus preventing future recurrence.
Acute attacks are managed by rapidly suppressing inflammation, typically using high-dose NSAIDs like indomethacin or colchicine. Colchicine works by disrupting microtubule function, which impairs the motility of leukocytes into the joint space, effectively blocking the acute inflammatory response to the crystals.
And for prevention?
For prevention, we target the underlying hyperuricemia. You can decrease production with allopurinol or febuxostat. They're xanthine oxidase inhibitors, blocking the enzyme that converts purines into uric acid. Or you can increase excretion with probenecid, which is a uricosuric drug that increases the renal excretion of uric acid by inhibiting its reabsorption in the renal tubules. And of course, diet control, restricting purine intake, remains a necessary adjunct.
Our final case, case 19, brings us to neuropathic injury. A newborn delivered breech presents with a right hand that is tightly contracted, fingers curled toward the palm, and noticeable atrophy in the hand muscles. This is a classic case of Klumpke palsy.
Klumpke palsy results from an injury to the lower trunk of the brachial plexus, specifically the C8 and T1 nerve roots. This is often due to birth injuries, particularly breech deliveries or traumatic shoulder dystocia, where excessive upward force is applied to the arm, stretching those lower roots. It results in a severe proximal brachial plexus neuropathy.
C8 and T1 contribute significantly to two major nerves. What are the resulting motor and sensory deficits?
C8 and T1 contribute heavily to the formation of the ulnar nerve and the median nerve. The motor deficits primarily involve the intrinsic hand muscles, the interosseous muscles, the third and fourth lumbricals, and the thenar and hypothenar eminence muscles. This results in atrophy, particularly of the thenar and hypothenar eminences. Sensory loss involves the medial side of the forearm and hand, following the distribution of the ulnar nerve.
The physical manifestation, the hand contraction, is often called the claw hand. Explain the specific mechanism by which ulnar nerve injury causes that particular deformity.
The claw hand occurs because the lumbrical muscles, which flex the MCP joints and extend the DIP and PIP joints, are partially denervated, the fourth and fifth lumbricals via the ulnar nerve. When the lumbricals are lost, the intrinsic hand muscles fail. The unopposed action of the extensor muscles causes hyperextension at the MCP joints, and the unopposed flexors cause the fingers to curl into flexion at the DIP and PIP joints. This results in the characteristic curled, clawed posture, particularly in the ring and little fingers.
Birth trauma is one cause, but what other insidious or traumatic sources can injure the lower trunk of the brachial plexus in an adult?
In adults, we have to consider secondary trauma or compression. This includes thoracic outlet syndrome, or TOS, where the C8-T1 roots are compressed as they pass through the narrow space between the clavicle and the first rib, sometimes by a hypertrophic scalenus minimus muscle or a congenital cervical rib.
And more ominously,
Most ominously, a Pancoast tumor, a malignant tumor at the apex of the lung, can grow and infiltrate those lower C8-T1 roots, causing Klumpke-like symptoms. This is often associated with Horner syndrome, mitosis, meiosis, and anhidrosis due to simultaneous damage to the sympathetic chain as it passes through the thoracic outlet.
so what does this all mean? We've successfully deep dived into 20 distinct clinical scenarios, ranging from the mechanical failure of a knee in case 7 to the decades-long autoimmune destruction of a joint in case 13. What becomes really clear is that the musculoskeletal system is the ultimate communicator. It's the canvas upon which internal, systemic chaos makes its most visible and often painful public appearance.
Absolutely. The massive breadth of this review, from the immediacy of a gunshot wound to the progression of fibrosis and scleroderma, it just emphasizes the profound interconnectedness of structure and function. We saw the inherent vulnerability of critical structures running along these anatomical highways, the neurovascular bundle under the rib in case 1, the portal connections of the spleen in case 3, or the medial circumflex arteries in a femoral fracture in case 5. These anatomical weak points, they dictate the severity of the trauma.
And we learned that strength is often just an illusion. The body's scaffolding, which appears so robust, is constantly being undermined, whether it's by defective genetic blueprints leading to brittle bones like an OI, or a missing stabilizing protein in the muscle like DMD in case 9, or the immune system just aggressively dismantling healthy cartilage in RA. True proficiency requires connecting that macro symptom, that chronic joint ache, that peculiar rash back to the specific microfailure that caused it.
And the key takeaway here is a recognition of pattern. Even seemingly localized failures, a gout flare, a chronic knee injury, are frequently underpinned by a systemic, invisible process. Chronic bone mineral loss like osteoporosis, hyperuricemia in case 20, or an inherited flaw in the very building block of connective tissue, like in case 12. These are all fundamental breakdowns in metabolic or genetic processes made manifest as a visible, palpable structure we call pain or deformity.
Which leaves us with this final provocative thought for you, the learner, to consider as you wrap up this deep dive. We rely on our skeleton, our skin, and our muscles every single second of every day. But how often is the structure we rely on merely a visible manifestation of a deeply hidden, constantly regulated, or perhaps failing molecular
It's
process?
a great question.
What seemingly localized pain might actually be the first knock on the door, signaling a fundamental systemic breakdown, a metabolic imbalance, a genetic flaw, or a silent autoimmune attack that has been accumulating in your body for years.
A fascinating area that continually demands that we connect the dots between the macroscopic symptoms and the microscopic reality. Thank you for diving deep with us.
We'll see you next time.